Hi, everyone. We are so glad that you are with us here today. We welcome you to this presentation on provider billing for behavioral health services within Medicaid school-based services, presented by the Medicaid School-Based Services Technical Assistance Center. My name is Jill Bonenkamp, and I'm an associate professor at the National Center for School Mental Health at the University of Maryland School of Medicine and a partner on the Medicaid SPSS Technical Assistance Center. We have a full agenda today where we will review the landscape of comprehensive school mental health, how Medicaid and Department of Education sources help to fund mental health services in schools, and then we'll dive deeper into the mechanisms and supports for provider billing for behavioral health within Medicaid school-based services. We are thrilled to have panelists from Minnesota, Michigan, and Colorado to share about this work in their state. We welcome you to use the Q&A feature on Zoom to drop in any questions you may have for the TAC, CMS, or for our panelists at any point during the presentation. By the end of the webinar, our goal is for you to walk away with practical examples and potential next steps to advance funding and billing for behavioral health services in schools in your community. The Medicaid School-Based Services Technical Assistance Center is part of the Bipartisan Safer Communities Act that directed the Department of Health and Services and the U.S. Department of Education to collaborate to assist states on specific activities designed to increase access to school-based health services, including mental health services. For Medicaid SPSS, the Bipartisan Safer Communities Act specifically addresses establishing responsibility for interagency coordination between state agencies and providing state Medicaid agencies and state education agencies with technical assistance necessary for them to access Medicaid to provide school-based services. Before we dive deeper into provider billing for school-based behavioral health, we will review comprehensive school mental health systems. Providing mental health treatment in schools is a key component of addressing the youth mental health crisis, as schools are one of the most common locations for youth to receive mental health services. And in addition to being a common location for mental health services for youth, comprehensive school mental health systems are also related to numerous positive academic and social outcomes for youth, and are related to early identification and treatment and positive school climate and safety. So when we talk about comprehensive school mental health systems, they include a full array of tiered supports and services, including mental health promotion and early intervention, and are built on a strong foundation of district and school professionals in strategic collaboration with students, families, and community and health and mental health partners. This graphic highlights the key features of comprehensive school mental health systems and comes from the Advancing Comprehensive School Mental Health Systems Guidance from the Field report, which is a great resource to reference. It provides a more in-depth overview of comprehensive school mental health best practices, as well as state and local examples. One of the key elements of a comprehensive school mental health system is that it provides a multi-tiered system of support, including mental health promotion activities for all community members, as you can see here in the blue, to increase positive mental health, targeted interventions to prevent small challenges from getting bigger, and targeted mental health intervention services for those who need them. School community partnerships seek to integrate partners seamlessly so that they are coordinated to meet the needs of students and families. And this graphic that you see here is exemplifying one example of a school community provider collaboration with community providers who may be located in schools, covering more intervention services. You can see that on the right-hand side, and school partners implementing more universal mental health promotion activities. We know that there is a wide range of needs and available providers across the US. And so, with that in mind, we know there's also great variability in the roles and responsibilities of different providers within a school setting. With that in mind, there are many different partners that support school mental health across the US, including both school-employed providers, community-employed school-based providers, education team members, and community health and mental health providers. Members of the school mental health care team can be Medicaid providers in the context of school-based services, and community providers may also bill Medicaid. And the updated guidance gives states greater flexibility to cover services provided by school-based healthcare providers, whose provider qualifications under state and local law may vary from qualifications from non-school-based providers of the same services, or whose scope of practice might be limited under state or local law to the school setting. According to the results of the 2022 School Pulse Panel, a study by the National Center for Education Statistics and the U.S. Census Bureau, just over half of public schools felt that they could effectively provide mental health services to students who need them. And of the public schools that did not strongly agree that they could effectively provide mental health services to all students in need, they identified insufficient mental health professional staff coverage to manage caseloads, and inadequate access to licensed mental health professionals were top two factors that limited their school's ability to provide mental health services. And this highlights the need to look comprehensively at potential providers. There are increasingly more innovative strategies to address school mental health workforce shortages, including diversifying school mental health providers, increasing the school mental health workforce pipeline, implementing school telehealth programs, facilitating partnerships with community providers, and supporting provider well-being. And many of these strategies and ongoing related innovation are being developed through the Bipartisan Safer Communities grant programs, including the School-Based Mental Health Services Grant and the Mental Health Services Professional Demonstration Grant. The Medicaid SPSS TAC hosted a virtual meeting last fall focused more in depth on comprehensive school mental health systems. We'll include the link here if you would like to go back and review it. There are numerous existing Medicaid and Department of Education sources to help fund mental health services in schools. The CMS Mental Health and Substance Use Disorder Action Plan highlights that schools are a key component to achieving the goals of the plan, including increasing access to prevention and treatment, improving engagement in care, and enhancing quality of care. And we know that Medicaid SPSS provides tremendous opportunity to help fund mental health services in schools. Similarly, there are also numerous Department of Education sources to help fund mental health services in schools, including Title I funds, Title II Part A funds, Title IV Part A funds, IDEA, and additional funding sources through the Bipartisan Safer Communities Act. Two of the Bipartisan Safer Communities Act grants are currently open for applications. We want to make sure we're flagging this for you, including the School-Based Mental Health Services Grant and the Mental Health Service Professional Grant. We also wanted to highlight the Raise the Bar for Children's Mental Health, Strategies to Sustain Innovation and Access to School-Based Services event that was held earlier this month, with presentations from the U.S. Secretary of Education and the U.S. Secretary of Health and Human Services. We encourage you to review the recording of the convening. We know that there is variation across the U.S. in state requirements for school-employed mental health providers and Medicaid billing. Examples of potentially eligible school mental health services include psychological assessments, individual and group counseling, and crisis intervention services. And examples of potentially eligible providers include psychologists and school psychologists, school counselors, and school social workers, to name a few. You can see more information in sections 3G and H of the Comprehensive Guide for Providers Requirements. We know that there are lots of opportunities to expand providers and services within the plan. And many of eligible school mental health services correspond with EPSDT benefits in many states. For example, psychosocial and behavioral assessments are part of most state EPSDT schedules. And just to note that these services must also be coverable under the 1905A of the Social Security Act and be medically necessary for the child. The school Medicaid fact sheets from the Healthy Schools Campaign initiative, Healthy Students, Promising Futures, is a resource to review eligible behavioral health services and providers across the states. That was developed in 2021. It's recommended to gather further information to go directly to the State Medicaid office website. State Medicaid and state education agencies often play a significant role in supporting billing. And there are many opportunities for Medicaid to advance school mental health services and supports by leveraging funding for federal grants to expand the number of providers who could ultimately bill Medicaid for services. In addition, there are opportunities to expand provider eligibility for Medicaid reimbursement, expand types of services offered in schools, and assess for alignment between providers and service coverage within state and Medicaid eligibility. Some examples of the ways that state education agencies and state Medicaid agencies are supporting behavioral health include biannual forums, differentiated training and technical assistance opportunities, some that are on a 101 level or a more advanced training, SharePoints to allow for sharing between common materials across districts, outreach to small rural districts, multi-district coordination for shared administrative support, and state and regional offices that work with districts to provide support and common billing codes. We are thrilled to have a rich panel presentation today where we will hear from 3 state examples of their efforts to increase and support provider billing for behavioral health services within Medicaid school health services. We are joined today by Scott Hutchins, the supervisor of the School Behavioral Health Unit at the Michigan Department of Education in the Office of Health and Safety, Julie Newer, Interagency Specialist at the Minnesota Department of Education, Olga Ginchin, the Program Administrator for the Colorado Department of Healthcare Policy and Financing, and Omar Estrada, a school health services consultant at the Colorado Department of Education. Thank you so much all for joining us today. We are extremely grateful for your time, and I will turn it over to Scott to kick us off.
Thank you, Jill, and thank you all of you that are on this call. It's definitely an honor and privilege to be here, and special shout out to all of our Michiganders out there. Exciting to be here with all of you and share the success and highlights of what we've been able to do. So as Jill mentioned, when you look at school-based services, we are very fortunate, and what I'm going to share today with Michigan is we had legislative support that many states are very jealous of. I'll just be perfectly honest with you. We are spoiled. We have an amazing support network with our legislators that started before the pandemic, before we had 2 violent tragedies that took place, one at the campus of a high school in Michigan and another one at Michigan State University. Our legislators were looking at ways to provide more comprehensive services within the schools and eliminate some of those barriers that Jill touched on. And so when we got that funding, the first thing we did was looked at ways to build out a comprehensive system, because we all know budgets change all the time, right? Not just our own personal budgets. When, for example, this week, I just got a letter in the mail saying, surprise, your adjustable rate mortgage just went up. You get ready to pay an extra $100 a month. Wasn't really expecting that, right? Same thing happens with state budgets, right? Our legislators change, priorities change. We have a governor, for example, that ran a platform on fixing the damn roads. She is starting to work towards that, but she hasn't accomplished that yet. So, got to find the money somewhere. What we want to make sure is we don't do that at the expense of this school-based services that we're starting to create. So, brings us to the National Center for School Mental Health. Amazing resources, as Jill talked about, that are available. We looked at the 8 core features as kind of our guidepost, if you will. As I said, I'm going to touch on the funding that our legislators have provided us. But when that came in, as I said, we felt like we were in an audition, an opportunity to show the legislators, show the rest of the state that, hey, we will make good on these funds. You are investing in the right way. Providing mental health, behavioral health services in schools is going to benefit our students and families for generations to come. And so, as I said, we knew we needed to do something. And so we started researching and fortunately came across, as I said, amazing resources within the National Center for School Mental Health, including those 8 core features. So, as I mentioned, not only were we spoiled because we had an amazing amount of support financially in our State School Aid Act, those are the funds that are legislatively approved each year by our legislators. We also, at the same time, amended our Medicaid state plan. Jill talked about right now the call to action from the White House across the country. They are asking states to amend their state plans. Again, we were very fortunate that we were able to do that at the same time that our legislators invested in providing funding for schools to add school-based services for all students, not just our not just our special education students. We wanted to create a sustainable funding model so that we weren't 100% reliant on the legislators each year. And so that's when, again, worked with our Department of Health and Human Services to amend our Medicaid state plan. So those two things came hand in hand. Again, that's very unique. Many other states that we've talked to are doing one or the other. We were able to do both. We were able to get that legislative funding, and we are also able to amend our Medicaid state plan at the same time. You can see from this first bullet, it started with a budget of around roughly $20 per student, or $30 million back in fiscal year 19 that was added to our budget to provide funding for, we have an intermediate school district structure in the state of Michigan. So it provided funding for our intermediate school districts to add helping professionals. Again, as I mentioned, at the same time, we amended our Medicaid state plan. Since that first year of funding, we've seen continued significant investments. As I said, we've gone through a pandemic. We've had 2 tragedies take place on campuses. So that $30 million, so you can see, again, with fiscal year 19, that $31.8 million. Fast forward to where we're at now, fiscal year 24, not only do we have $112.8 million in recurring, but $343 million in non-recurring funds. As I mentioned before, we're very fortunate. I realize that other states out there are probably looking at like, whoa, how did you pull that off? Just like the rest of the political atmosphere across the country, our legislators are having difficulty deciding on how to use funds, right, and how to allocate them. But one thing that is not a partisan issue right now is school health and school safety. Fortunately, doesn't matter what side of the aisle you're on, we can all agree that funding is needed in our schools to provide behavioral health services and to make sure all of our students and staff are feeling safe and healthy. So again, you see significant investment. Where do those funds come from? Many of you may be thinking. Recently in Michigan, we've done 2 significant things that have raised significant amount of funding. We legalized marijuana and we legalized gambling. So again, that's bringing a tremendous amount of income into the state. And as I mentioned before, right now, legislators are having a very difficult time deciding on how to use those funds. But one thing they're not arguing over is school health and safety. So as I mentioned before, right now, my colleague Kevin Bauer, who's on this call from the Department of Health and Human Services, uses the expression, we're the belle of the ball. we are seeing the impact of these funds coming to improving school health and improving school safety. Because as I said, that's one of the things right now that's not a bipartisan issue. So we're very fortunate. And as I also mentioned, it's an audition for us. It's a call to action. Whatever term you want to use, we know we have an opportunity here to show the legislators that it was the right investment. And in 5 years from now, don't take that money away, because our students and our families across the state are going to continue to um, improve their quality of life because of this investment. I don't know if we'll continue to see that high rate of non-recurring funds at that 343 million, but at a minimum, if we can continue to see a recurring investment that adds funds so that we can again build out this comprehensive school mental health system and not turn around and lay off helping professionals. So I wanted to share with you a roadmap. Again, we know that we're very fortunate in Michigan. Not only has our Medicaid state plan already been amended, not only do we have an amazing support from our legislators when other people don't even have anything more than, let's say, a Project Aware grant or a grant from NIMH or whatever it happens to be. So if you were to look where you might want to get started, here's an idea for a roadmap. First and foremost, conducting a needs assessment. National Center for School Mental Health has some amazing tools. Their SHAPE assessment tools can be filled out by a local district, an intermediate district. They can also be done at the state level. They are great tools that I would highly recommend you look at. Again, starts with that needs assessment so that you can identify a common mission or a common goal to get started. From there, develop that steering committee, right? Identify representatives from your Department of Health and Human Services, your Department of Education, your school leaders, and your community advocates and legislative champions. From there, identify potential funding sources. Again, we're very fortunate that we have funding directly in our State School Aid Act, and we've done our Medicaid expansion. Two significant things, but there are plenty of federal grants out there. Jill already shared some from the feds that can be taken advantage of. Then from there, identify your early adopters. Find your local education agencies. Find your schools that are willing to hold their hand up and say, you know what, yes, pick me, pick me. We'll be your guinea pig, right? Start somewhere, find your early adopters, and then build on the success of those early adopters and make those changes as necessary. And the last one, which again is very significant for Michigan's progress, is identifying a common technology infrastructure to establish those best practices and integration. I cannot stress enough how much this has significantly helped us in Michigan. And I'll share in the next slide what that looks like. So we chose a platform called BH Works. The company itself is MD Logics. Their platform is BH Works. Again, we use that to connect our students to services more efficiently. So you can see here, the bottom of that pyramid, it starts with that first initial referral or screener. So, a parent, guardian suggests that their child is struggling, a trusted adult at school sees the child is struggling, they make a referral, or a screener takes place on a student, a universal screener, students are identified. From there, next step is to do an assessment and determine if services are appropriate. All of that we can do within a platform that we have made available to the state. What that service delivery looks like, again, an entire care coordination platform. So from referral to consent to developing a plan of care, progress notes, checking the student, discharge, etc., all can be done right within a single platform. So I will close with that. If there are any questions, Jill, my contact information will be available, and I will stay on and keep an eye on the chat.
Thank you so much, Scott, for talking about what this looks like in Michigan. We had a question come in about whether the funding that Michigan has invested goes to all districts through the state through a state per student funding model or elsewhere.
That's an outstanding question. So actually it's both. So in the recurring funds that I mentioned, those are directly allocated to our intermediate school districts. And everybody in the beginning got one equal amount of funding. In Michigan, I told you about, we have an intermediate school district structure. We have some intermediate school districts with less than 10,000 students. We have others in the Detroit area, our largest area in the state, with over 240,000 students. They were the first year getting the same amount of money. You can imagine, the concern with that. Since then, we've gone from this everybody gets the same amount to a more per pupil allocation. So now intermediate school districts are getting a base amount, but then an additional per pupil allocation. The other non-recurring funds that I reference, those are 100% based on student population. So that is an allocation. A large amount of money is based on the number of students within the intermediate school districts or local districts. So we have both models.
Scott, and one more question about the needs assessment that you mentioned and whether that is accessible to the public.
I will post the link to the SHAPE tool assessments. Absolutely.
Thanks, Scott. Thank you so much for sharing about this. Please feel free to put any other questions in the Q&A or chat for Scott. And with that, we'll go ahead and switch gears and turn it over to our next panelist, Julie Nuhr, who'll be sharing about their work in Minnesota.
Hi, thank you, Jill. Scott's a hard one to follow. Just saying, Michigan. But thank you for inviting me. I'm delighted to share with you all what's going on in Minnesota. I have 4 slides, and really what the theme or what I'm going to be discussing is really about what Minnesota looks like, what's going on at our legislation right now, and then how do we communicate and do and train our LEAs. So I'm hoping to do that all in less than 10 minutes. So this first slide, I'm just going to talk a little bit about who are we? Minnesota, if you take a look at the Medicaid and Minnesota fact sheet, we have 1 in 3 people with disabilities in the state and 3 in 10 children in the state. The data that I have here is from the 21-22 school year. We have over 151,000 kiddos with a disability in Minnesota. 67% of the kiddos with a disability of EBD are also eligible for free and reduced lunch. Over 44,000 of the children that are enrolled in MHCP, which is the Minnesota Healthcare Programs, were billed. Their IEP services or IFSP services were billed. In the 21-22 school year, we Minnesota schools received over $57 million in federal Medicaid reimbursement. Unfortunately, only 1.5% or approximately 1.5% of that $57 million was for behavioral health services. So some of the reasons why that is in Minnesota is to be eligible for reimbursement or to seek reimbursement for behavioral health services in Minnesota, you do need to be certified with CTSS, which is Children's Therapeutic Services and Supports. It's like a mental health benefit package for children. But with that, to become certified, you need 2 mental health professionals. There's a lot of additional paperwork. And the reimbursement simply just didn't cover the cost of that additional paperwork that they needed to do. And frankly, we just didn't have the staff. Like many of you all, we needed 2 mental health professionals to be certified. In our rural communities, that many of them don't even have 1 mental health professional. So those were huge equity issues for us. And so schools just simply didn't participate. I'm going to digress from this in just a little bit, just to say, Minnesota, we have like over 500 districts in our state. We have a lot of rural, low income. We have tribal communities in the state. So we have a very diverse population. So I just wanted to put that out there as well. So this is what's going on at our legislation right now. Well, let me just give you some historical background. I've been doing this for a long time. I've been with the school district for about 12 years and now at the state for 6. And so I've been working on this for about 18 years now. But in the 21-22 school year, there was legislation that passed that mandated that MDE, the Minnesota Department of Education, and the Department of Human Services come together and really look at CTSS and look at where we could reduce some of the burden and barriers on schools in accessing behavioral health services. And so in response to that, we formed a CTSS work group, and that brought in not only school providers, but community providers. And we all just, we met for many months to determine and come up with recommendations of what we felt would help this benefit, and then and reduce some of those barriers for schools to seek additional behavioral health reimbursement from Medicaid. And this is still back in we're still talking about IEP or IFSP. So unlike Scott in his conversation, we're still really looking at our IEP population and how we can bring in Medicaid reimbursement for our IEP kiddos. Moving forward to the 2023, we had just a great bunch of stakeholder engagement and advocacy around this, between our school districts, our associations, our parent advisory committees, all came together and really created this multi-agency letter of support to our legislators about the barriers that CTSS was causing to our schools in accessing Medicaid funds. And so last year we were fortunate enough, legislation did pass. And what that legislation looked like was really to allow schools to seek reimbursement for behavioral health services in the same way they do all other health-related services. It removed the requirements for CTSS. It allowed our IEP, our IFSP, or eval to determine that medical necessity and need for seeking reimbursement. It expanded the services, and then it also, as many of you need, or as many of you also are looking for, that expanded provider list, that expanded list of providers who are able to provide and seek reimbursement for behavioral health services. So that was huge. In November 20th or 30th of last year, Minnesota, they sent through a state plan amendment. CMS was awesome and got back to us fairly quickly, considering it was the holidays, with just minimal recommendations. There was some communications back and forth between our Department of Human Services and CMS, which now led to an amendment to last year's legislation that passed, which is right now in our legislation. It should go to conference committee. We're hoping like tomorrow or maybe next week, and really hoping next month that this will be passed. So fingers crossed with that. The changes were minimal. It still allowed for the expansion of services that we were able to seek reimbursement for. And it still allowed for additional practitioners to provide services under the supervision of our professionals. And so we were really fortunate in working together with DHS. I think the rationale behind the amended language was just to come to more of an alignment, more parity with our community providers and how they're accessing Medicaid reimbursement for behavioral health services, and really trying to blend those two. And so, yeah, fingers crossed. And like I said, we're really hoping for that implementation the next school year, which is the 24-25 school year. And so what we're trying to do, or what we have done, is on the front end, we've formed a behavioral health work group. And this work group has, mental health professionals, practitioners, we have administrators, we have our vendors, we have our state agencies, all on this behavioral health work group that we've split up into subgroups and really kind of pinned down these four areas of not really concerns, but we're really trying to anticipate what the questions are going to be moving forward when we go to implement this program or this new benefit at the start of the next school year. So we have a subgroup looking at policy when we do get policy, right? looking at due process, how we can satisfy due process and medical necessity, looking at our funding, how are our staff funded? Is that appropriate? Do we need to move that staff around? Do we need to make sure that we have certain staff in place to be able to do that supervision and be part of those IEP teams? And so really working hard to come up with some training tools for our school districts moving forward. So when they do go to implement, and we're hoping to train this summer too, which is kind of unfortunate because school staff aren't there in the summer, but we can only do what we can do, right? So really hoping that we can answer those front end questions, address some of those issues up front so we can create a training tool for schools to move forward for them to hopefully implement, or at least some try to implement this benefit starting this next school year. I talked about training a little bit, and I just wanted to share what we have in Minnesota and how we communicate with our LEAs and how we train our LEAs. In addition to the behavioral health work groups, we have a Medicaid and education advisory team. This has been since the early 2000s, we've had this work group, and they look at all health related services that are being provided and billed in the schools, in addition to behavioral health, but they also help facilitate and the spring forum, facilitate and plan the spring forum. We just finished the spring forum last week, and we had about 250 attendees. It is in person, it's virtual, and it's recorded. It went really well. We have a meet and greet the night before, so it's really informal, casual, just an opportunity for people to network and talk that they don't get to during the school year. In addition to the fall or the spring forums, we also have fall trainings. MDE, in partnership with the Department of Human Services, put on fall trainings for the school districts. Usually we go to the different regions and travel. And then we also just recently created some 101 modules for our districts to be able to reference. And I really have to give kudos to our Medicaid and Education Advisory team. They created these modules and took this really dry information and really created videos that are entertaining and engaging and fun to watch. And so I think we have 9 of them out there right now, and coming soon, hopefully a mental health one as well. Those are all out on our SharePoint site. We have all our trainings, all our forums, all announcements, communications, and like those 101s, all available on the SharePoint site. So a district just emails me and I give them access to the SharePoint site, and they then have access to all this information. Of course, our Department of Human Services has a provider list, and they can send out updates, announcements through that. And we also have the Minnesota Department of Education listserv, where I can send out notifications and through the listserv as well. So a lot of different avenues to be able to reach out to our districts and make the trainings is available to as many people as we can. So hopefully I didn't run over. I was talking really fast.
You were great, and you gave us a wealth of information. How exciting to hear about just the many different ways that you're connecting with districts and giving them the opportunity to connect with one another and providing training and technical assistance. So thank you so much for giving us.
And can I just add too, I was just thinking of what, Scott, they have grants at Michigan too. I just wanted to mention that Minnesota also does have school-linked mental health grants that is available to the schools. However, that is funneled through the Minnesota Department of Human Services, and that's why I didn't really talk too much about it, because it's really funneled through them, and they organize and distribute those funds.
I appreciate you flagging that as well.
Yeah.
And again, thank you so much for giving an overview of that. Please feel free to put in the Q&A any questions for Julie or for Scott or for our upcoming panelists. You also have representatives from the TAC and from CMS. You're welcome to please put questions into the Q&A so we can track and make sure to respond to those as opposed to putting them in the chat. Thank you so much, Julie. And without further ado, we will turn it over to the Colorado team, and I'll turn it over to Olga and Omar to kick us off. Thank you so much for being with us today.
Well, thank you, Jill, and hello again, everyone from beautiful Colorado. First, just wanted to give you all some background on why Colorado and what really prompted Colorado to add school psychologists to our program in the first place. First, it really started with the 2014 State Medicaid director letter that opened up the possibility of expanding to free care. And that's really what started discussions about the addition of school psychologists to our program. Before that letter, school qualifications had to match qualifications in the community. So our local education agencies could only have PhD level psychologists with a license from the Department of Regulatory Agencies, DORA, on the direct service staff pool list. Of course, most psychologists working in schools are school psychologists. We also considered adding school psychologists because it could result in significant changes in reimbursement dollars and hopefully leading to increased support for students. It's also important to consider adding school psychologists to the program here because mental and behavioral health is a really big priority in Colorado. Next, just wanted to give you a really high-level overview of the school health services program in Colorado. We are a cost-based program. We are not a fee-for-service program, and we have a 1/12 methodology for interim payments. We have a statewide time study percentage for all participating LEAs in Colorado, and we have two cost pools, the direct service cost pool and the administrative cost pool. We started our free care expansion in Colorado on October 1st of 2020. And at that time, we expanded to school psychologists, but with supervision. We saw at that time that there was a need for adding more school psychologists to further increase those qualified providers. So we completed some analysis prior to the addition of school psychologists without that supervision. We thought that adding more school psychologists or more licensed providers should increase reimbursement, but it depends on their impact on the random moment time study, that RMTS. We conducted some analysis in 2019 prior to the free care launch to see the impact of adding school psychologists. At that time, school psychologists were on the administrative cost pool, so LEAs didn't get reimbursed for the direct services, which is really the bulk of reimbursement for school-based services. Originally, we thought they could be added under rehabilitative services because another expansion state had added school psychologists under rehabilitative services, but all states are different, and that did not work for Colorado. How it was ultimately approved is CMS approved school psychologists as other licensed practitioners, which added them to the program as licensed providers. So that supervision from a PhD DORA licensed psychologist was no longer required. And that was approved because they're licensed by another state agency, or in other words, from our state plan amendment, our SPA, they're otherwise licensed by the state. The language for school psychologists in the state plan is services of licensed school psychologists within their scope of practice according to state law. And that opened up the opportunity for master's levels and above instead of requiring that PhD. In Colorado, the specific requirement is special services provider license from the Colorado Department of Education, with an endorsement of school psychology, and that was effective October 1 of 2022. So this was prior to all that the CMS comprehensive guide that came out in May of 2023, which further encouraged additional providers. And what happened after the approval is that many of those school psychologists were switched from that administrative outreach cost pool to the direct service. And making that change in cost pools now required that school psychologists are responsible for direct service billing, but they still get credit for the outreach and enrollment activities that they got when they were just on that administrative cost pool. We have a lot of training and resources in place, both before and after this change. But first, it was important to help LEAs understand that school psychologists still get credit for program and administration, for outreach activities, even though they moved over to that direct service cost pool. Training LEAs was important before school psychologists were added to the direct service staff pool, is to make sure that they're doing reimbursable activities and that they didn't dilute the time study. And we communicated the importance of school psychologists answering the RMTS. We conducted research, like Omar and I attended the annual Colorado Society for School Psychologists meeting and explained the changes that were happening and the importance of answering that RMTS, and that those school psychologists are now responsible for that direct service billing. We train to make sure that school psychologists have services in a plan of care with that appropriate scope, duration, frequency, and of course that medical necessity for services. And we incorporated all these changes into our existing training structure, including stakeholder discussions. We have a group of more experienced program coordinators from across the state that we frequently seek input from. Our monthly mentorship sessions, our quarterly newsletters, our annual and mid-year training sessions. We have an annual training that's usually a day-long training about the beginning of August. And then we have a mid-year training like early February that's typically a half-day training. Incorporated those changes into those trainings, as well as our help desk and our program reviews, like our desk reviews and our comprehensive reviews, to ensure that LEAs were compliant with the new requirements. And also we incorporated that into our online resources, like our program manual and our recorded training sessions that we also have on our program website. And that is all I have for the Medicaid side of the program in Colorado. I'm going to hand it over to Omar for the education side.
Thank you, Olga. Here in the education side, we help our participants here in the program, our LEAs, spend, and we track those dollars that they get from the billing side of the program. We do this through a few different ways. The actual spending is done through what we call the local services plan. So this spending plan is over a 5-year period. It's in state statute. It's actually very unique to Colorado. And it's also in statute that they have to get the local community input to put this plan together. So they can work with their local public health agency, internal staff, parents, students, whatever is best for that local community to get what health services are needed for their students. So once they put this plan together over the 5-year period, we track how they actually spent those dollars in each one of those years through something we call the reimbursement spending report. And that reimbursement spending report, we organize spending categories across 6 different categories. Mental health is actually its own category. So the last fiscal year that we have that's publicly available is fiscal year 22, where we saw $16.7 million in spending in that category. That was an increase of like $3 million from the previous fiscal year. That $16.7 million, about 95% of it went to FTE, or full-time equivalent, or contracted personnel. So that was about 205, 207 FTE across the state. And total spending really was about $66 million across the state. Nursing services tends to be the #1 category, but mental health is really right behind it. So I mentioned 95% is going to, your school psychs, school counselors, anyone that is fulfilling a mental health service. That's what would be in that category. The rest of it would go into mental health related equipment, materials, supplies, training, assessment costs, screening costs, or any support costs to make sure that our students get what they need, make sure they're fully supported to be ready to go learning in class. So really the spending is going to be very specific to the local community, whatever they need, whatever they've identified, they put it in their plan. We review it just to make sure that these dollars are going to our students. And I'm going to stop it right there and pass it over back to you, Jill.
Great. Thank you so much, Olga and Omar, for talking through your process for school psychologists, how you're supporting LEAs in these changes and this work. And wow, the impact of those FTEs and dollars coming back into the system. We are extremely grateful for all of our panelists' time and for being willing to present today. We know that states and LEAs and folks across the country are in different places with this work. We hope that this range of panelists and discussion today has given you the opportunity to see a piece of where your school community is. We want to thank our panelists so much for their time, for sharing all that you do to enhance and support provider billing for behavioral health services within school-based services of Medicaid. We are so grateful for your time. We're grateful for everyone's time for joining us today. If you have any additional questions, please feel free to reach out to the TAC. You can reach us at our website, which we'll have up here on the next slide. We are grateful for everyone for joining us today. And thank you so much for your time. And we look forward to continuing to connect with you over the coming months as we work together to partner to advance school-based services. We hope you have a wonderful rest of your day. Thank you so much.